Pupil and oculoplasty, or various intersection of different pupillary reactions or the size with the oculoplastic practice. I've picked up two or three cases. This is a 22-year-old female with mild ptosis, complains of intense headache, and she does remember that she had a fall 3 days ago, though she didn't really attach too much of importance to it. Her visual acuity were both 6, 6, and 6 in both the eyes. uh, so one thing which I want to emphasize, this is how patient looked like. Left eye, mild ptosis, and headache following a trauma which she did not really care much about. But what she was found to have, not very clear here, is a difference in size of the pupil, where the left pupil was a little smaller than the right pupil. So when you are fraught with this clinical scenario where there is a difference in the size of the pupil, the next step in clinical practice would be to see what happens to that difference in size of the pupil when the room lights are off and on. We might require a reference light which is not very bright in our population, because the iris color is dark and we can't really see pupil too well if the room light is completely off. So what happens to the difference in size of the pupil when the room lights are off versus on? And in this patient, if you see carefully, when the room lights were dim, this pupil dilated while this pupil did not. When there is a bright light, both pupils constricted, so the anisocoria was worse in the dim light. So in a dim light, when the room lights are off and there is not much of an ambient illumination, pupils are supposed to dilate. And that dilatation is brought about by sympathetic system. So if a sympathetic system on this side is not functioning, is where this pupil will not dilate, right pupil will dilate, making anisocoria worse in a dim light. So what you are dealing with here is a probable Horner syndrome, because patient also has a mild ptosis. Now, why this is important? This is another example of an isocoria where you can clearly see that the left pupil is much smaller than the right pupil. So Horner syndrome with pain, and there are three different anatomical areas where you can look where patient complain of pain, is an absolute medical emergency. And scenario number one can be an acute facial or neck pain, where patient might be harboring carotid artery dissection, and Horner syndrome being one of the features. Why it is important for us to know is one which, in this paper which came out from Atlanta, 50% of the patients who had ICAD, they actually came to us first. And that's the reason why a potentially fatal condition, or condition which can produce quite a bit of morbidity, we should not be missing out, because half of them present to us first. Now, why it is important from the medical standpoint, 60% have a permanent neurological damage and 5% mortality. So that's about facial and neck pain. Horner syndrome with shoulder, scapula, arm, or hand pain can be a sign of apical lung tumor, Pancoast tumor. And 20 to 50% of all Pancoast tumor had Horner syndrome on presentation. So that's the reason why importance of knowing about a shoulder pain. And third is Horner syndrome with unilateral headache, which can be because of trigeminal neuralgia. Generally, this headache would be cyclical but can be continuous, and this is something which will be dealt with by neurologist. So that's about anisocoria, which was worse in a dim light. Another example of pupil and ptosis is this. So see, patient has a right ptosis, and when you check ocular motility with torchlight, you'll be able to see that the pupil on the affected side is larger than the left side. So a ptosis with large pupil on the side of the disease, and you'll find here that mild uh, limitation of ocular motility and a significant or a impressive limitation of motility when patient tries to elevate the eye. So partial third node palsy with involvement of pupil, again a medical emergency. The reason being, 10% of these patients who have third node palsy with pupil involvement can pass away if they have aneurysm of posterior communicating artery. 50% of them die within 1 month, and rest, the survivor would have permanent residual neurological deficits. So a third node palsy, a ptosis with larger pupil on the same side, again a medical emergency, and these patients would require angiography apart from CT or MRI scan. Another important point to note in patients with third node palsy, this is a young guy who had a third node palsy, recovered was never imaged and came back with this kind of clinical picture. You can see there is a residual ptosis of the left side. And here, when he adducts, you can clearly see there is a widening of palpebral fissure. This sign is called inverse Duane syndrome, because generally Duane's you probably expect a retraction of the globe. So this is a sign of aberrant regeneration. Again, something which you should not ignore. If patient was never imaged and there was no history of trauma, then these patients also would require angiography, because aberrant regeneration of third nerve is almost always because of compression of third nerve or because of trauma. I'll end with this case where not strictly oculoplasty, but the patient who can complain of persistent near vision difficulty in somebody who is in presbyopic age group. But a sign to look for would be another anisocoria, and here you can see the left pupil being little larger than the right pupil. And this anisocoria in this patient was worse in a bright room light environment. So this is an example of AD syndrome, and a simple way to take care of it is to instill diluted pilocarpine. You see that the left pupil, which was larger, has now become normal size. So that's about pupil, larger pupil, smaller pupil, and a third nerve palsy. Now this is another patient with ptosis with a complete limitation of ocular motility, no adduction, abduction, elevation, and depression. And these are the patients where another important pupillary test, that is pupillary reflex, becomes very important. And this is an example of a swinging flashlight test, where you make sure that each pupil is illuminated for equal amount of time and at the same angle. And this is a cartoon showing patient having left RAPD. Just a few tips is that it should be done, the swinging flashlight test should be done in dark room, patient fixating at a distant target, uniform focused light source, avoid near reflex and better view of pupil by shining light from side and below. So in nutshell, pupil and oculoplasty can have three potential overlap. Anisocoria being worse in a dim light, that being Horner syndrome, anisocoria worse in a bright light with ptosis, third nerve palsy, and RAPD. I thank you once again.